Hello, PsychU community, and welcome to today's discussion with our bipolar section advisor, Dr. Joseph Goldberg. Thank you for joining us today, Dr. Goldberg. Thank you. I am Dr. Dri Wang, Senior Medical Science Liaison for Otsuka Pharmaceutical Development and Commercialization. I'll be serving as the host for our discussion today. Let me first introduce Dr. Goldberg to you. Dr. Joseph Goldberg is a Clinical Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai. He was site principal investigator at the Weill Cornell Medical Center for the NIMH STEP BD program. He has published over 200 peer-reviewed papers on topics related mainly to the treatment and clinical features of bipolar disorder, as well as 3 books on bipolar disorder and psychopharmacology. Today's presentation is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Lundbeck LLC. We're both committed supporters of the mental health treatment community. Speakers are paid consultants to OPDC. These are all the PsychU rules of engagement you can review at your leisure. The information provided during this program is intended for your educational benefit only. There are no CME or CEU credits that are offered. It's not intended, nor is it a substitute for medical care or advice or professional diagnosis. Users seeking medical advice should consult with their physician or other healthcare professionals. Okay, so let me start with the commentary that you have recently published in the Journal of Clinical Psychiatry. Most of our discussions today will revolve around this commentary. For the audience, if you're interested in reading the article, the commentary in its entirety, you can pull it up. The reference is at the very bottom of this slide. The article is called Psychiatry Niche Role in the COVID-19 Pandemic. And Dr. Goldberg, you're practicing in New York, which is considered the epicenter of the national pandemic. It's been a couple months now into the pandemic. So let me start with asking you, how has it been since it first began, and how has it differed from the beginning until now?
So one thing about this complex condition that's affecting all of us is its changing nature. It began with a crisis around bracing for the impact of the expected surge of cases that were feared to overrun hospitals, cause the redeployment of non-intensivists and even non-primary care clinicians like psychiatrists into primary care settings and emergency rooms and ICUs, and the setting up of ancillary satellite hospitals and in Central Park and things like that. And where I am in New York, we took a big deep breath and we braced, and we survived that first phase. The stay-at-home policies, the notion of flattening the curve was really meant to quell not the virus, but the spread of the virus and the rampantness with which the healthcare system could be so quickly overrun if unspeakably high numbers of patients came to hospitals and sought intensive care treatment that was just overextending the resources that were there. So in the first weeks of this crisis, this epidemic, we braced. We looked for our personal protective equipment. We made sure we had ventilators, and we got through that phase. And the numbers were high. And in the world of psychiatry, a lot of consultation to patients who were presenting with agitation, with anxiety, with pre-existing psychiatric problems, or just fear, and their families, and the frontline workers. And that in many ways was, I think, the first chunk of this problem. With the stay-at-home policies, the virus hasn't gone away, but the cases have diminished, at least the cases that get noted. That means people that are coming to hospitals. Fewer people are coming to hospitals. People are scared to come to hospitals. People are staying at home more. It's sort of brought a new next phase, I think, of this problem, which is really the big challenge of reopening the country, as they say, as opposed to staying home and staying safe. So there's really arguments on both sides of that. One is staying home and staying safe means I'm not going to put myself in proximal exposure to an environment that I'm likely to get infected with this virus, and I don't know if I'll end up being in the 90+% of people who gets the virus and has a fairly indolent course, or in the smaller but significant minority where it could be life-threatening. So that's the conservative view. The other side, though, is people do have other ailments and problems, medical, psychiatric, and to not seek care for that puts them at risk for problems from their non-COVID related medical and psychiatric ailments basically falling through the cracks or not being treated or taken care of. So this next phase has been a real dilemma. We've passed the surge, but now the question is, how do we safely reopen things in the country without triggering a new surge of just lots of more cases coming forward because of crowding and exposures, but also being able to treat patients who have ailments other than COVID-19. Those are the people that have been the conditions that have been sort of marginalized, as our focus the first month or so has just been around COVID-19.
Yeah, I think, we all have heard in the news about, the Spanish flu of 1918 and how it was a second wave where people sort of relaxed their guard, where most of the deaths and the mortality occurred. On that note, I wanted to read a quote from your commentary that I thought was especially poignant. You stated here, "A pandemic creates its own objective reality as a backdrop for all forms of psychopathology. Do economic downturns, job layoffs, prolonged school and business closings, and threatened supply chain disruptions lend validation to depressive nihilism? Do hand-washing mandates become a paradoxical injunction for patients with contamination-fearful obsessive-compulsive disorder?" On that note, how would you then distinguish between normal to pathological response to stress in this environment?
So we have an objective and unprecedented level of stress that's facing us. More than anything, I think this crisis from a mental health standpoint is a challenge to resilience and the capacity to bounce back from stresses. So on several levels, when confronted with enormous crushing stresses, economic, educational, social, familial, disruption to daily routines, and so on, anyone will find that stress enormous. The social isolation comes at we're social creatures to have the kind of social isolation as opposed to physical isolation. It just makes it all the more difficult to be able to exercise resilience skills. So we have this backdrop of enormous stress, and the challenge, I think, is to be able to respond to stress with adaptation. It's often said that stress follows a kind of an inverted U-shaped curve. You need enough stress in life to be able to perform. Stress, in some ways, challenges us to be attentive and mindful and problem solve. Not enough stress, we get lackadaisical. We're not in the game. We're passive. From an evolutionary standpoint, we need a certain level of stress to be able to assess threats in the environment, but then to use that anxiety from the stress to respond and formulate a response. If you go past the apex of the U-shaped curve, stress and anxiety start to become counterproductive. And at that point, it becomes paralyzing. And that's where I think it becomes pathological stress. This is not just in the mental illness realm of anxiety disorders. It's really, I think, in terms of just human response to stress. An overstressed system becomes paralyzed. It loses the ability to problem solve. So when I'm speaking with my own patients, for example, I'll often talk about the difference between demoralization and depression. Demoralization is catastrophic things have happened. Morale is lost. It's really hard to find optimism. It becomes more of a challenge to rally. Depression is when it reaches into the realm of I give up and I can no longer problem solve. I've lost the will and the drive and the initiative to even want to rally and to problem solve. It's a fine line in some respects, and certainly someone who has a pre-existing condition like depression or an anxiety disorder or a substance use disorder or any psychiatric disorder may be especially vulnerable for anxiety to tip past that apex into the counterproductive realm or for reactivation of an underlying psychiatric condition. But I think our challenge as mental health professionals is really to try to keep patients focused on the task at hand, which is to problem solve, to rely on their sense of resilience and try to foster it and build it, to help them maintain a sense of optimism, and to remind people really to bring out the inner fighter within them to get through just a very tough time without succumbing to the overwhelming potential of something like this saturating their capacity.
How would you describe pandemic adjustment disorder?
So in crisis psychiatry, people talk about, in the initial phases of response to a stress, adaptive responses to stress and maladaptive responses to stress. Technically speaking, in the first few days and weeks after an initial exposure to a great stress, say a hurricane or an earthquake or acts of violence, or in this case, a pandemic. Stress can tip into maladaptive behaviors, poor problem-solving skills, poor coping skills. It can disrupt sleep. It can change appetite. It can lead to an increased sort of autonomic hyperarousal state. If those features carry forward for at least a month, according to the DSM, that's where we start to contemplate the notion of frank post-traumatic stress disorder. And more technically, post-traumatic stress disorder is thought to involve a life-threatening exposure. Arguably, I mean, I work with frontline workers in medical settings. I've known physicians that are writing death certificates. This was more so in the beginning of the pandemic, but hand over fist, and ventilating patients. So I think the first line responders are especially vulnerable to the life-threatening kind of exposure that they've experienced, and the sense of autonomic overwhelm, fear response that comes. So in this next phase of the illness, or the next phase of the pandemic, as time has gone by, as the surge has passed, we start to worry about post-traumatic stress disorder, especially in those who were first responders or family members or even patients themselves who come off of ventilators. But short of PTSD, to your question, in those first few days and weeks, technically an acute stress disorder or an adjustment disorder is where there are brewing symptoms of an overwhelming stress response, a sense of autonomic dysregulation, maybe trouble sleeping, trouble managing anxiety. We want to be watchful that that does not evolve into PTSD. We want to assure that patients are able to maintain self-care and not fall into patterns and traps that are maladaptive, like misusing substances, losing a sense of routine and structure through the day. The patients tell me one day flows into the next. You know, what day is today, and why even bother getting up? It's as if you're in a stimulus deprivation tank from the monotony. In this next phase of the pandemic, the novelty is kind of gone, and now it's another day, it's another day, it's another day. So I think the abnormal stress responses have to do with losing a sense of problem solving, losing your confidence. It's very challenging for everyone that I know to maintain that sense of purposeful forward direction, but I think that's what can separate an adaptive stress response from a potentially maladaptive.
What do you see as the role of psychiatrists in crisis work? I know so many things have changed. So many of my customers have told me that they've had to move to telepsychiatry in short order, where there were no infrastructure supporting that beforehand. And everything is sort of having to learn trial by fire. Have you and your colleagues, have you been doing telepsychiatry pre-COVID, or have you implemented it because of COVID? Can you tell me a little bit more about that and the role of psychiatrists in crisis work?
Sure. So, a mental health professional that I know who's an inpatient hospitalist is practicing telepsychiatry at the moment. It's a mixed blessing. It is sure a whole lot better than not having that resource to be able to communicate with patients or with their families. The visual screens, just as we're doing now with Zoom, gives us much more of an eye into what's happening in someone's world and their life than if we're just talking on the phone or struggling to communicate. It does permit visits. It's not just obviously in psychiatry and mental health, primary care, dermatology, most medical specialties that are not procedurally based or emergency based are using telemedicine at this point. So it's been a lifesaver, I think, to be able to maintain contact with patients. One of the points I made in that article was that, if the office is closed, I guess I'll take a little break from treatment, and I'm sure my depression won't come back, or I don't think I have to worry about my substance use disorder getting worse. So one of my initial concerns about the pandemic was that some patients might fall off the radar or just call and say, I'm stressed, can I have a higher dose of a benzodiazepine? And the point I make is to not reflexively respond to those kinds of requests without an inquiry. How are you doing? How are you managing all the stresses that are going on? If you're furloughed from work, if you've lost your job, if the economics and the social crushing effects of this are so operative, let's at the very least talk and assess. So telemedicine has been really life-saving, I think, no exaggeration, for a lot of people to be able to have access for assessment. I've had more than a few of my own patients where hadn't heard from you in over a year, and now they're calling for a refill of something, and now's a really excellent time to check in and see how people are coping and managing. It's been eye-opening and very helpful to me as an observer and a clinician, and I think for them as patients as well. On the downside, I think, of telepsychiatry, So things get lost in translation. It's much harder, I think, to take care of people with very complex needs or more far-reaching problems. If someone is presenting, say, with depression and there's some breaking through of symptoms that's relatively manageable with pharmacology or with augmenting with a psychotherapy, that's different from someone where there's a real sense of medical urgency or chaos. I can't just say, why don't you go to the ER? We're assessing suicide in a suboptimal way. I can't really call 911 as readily. Not that I like to do that ever, but if I'm really concerned about someone's safety, it's not so easy just to say go to the ER. Nobody wants to go to the ER in the era of COVID. Or if someone needs a higher level of care. This has been, for me, one of the big changes I've noticed since this epidemic has started. Most of my private practice is consultations and second opinions in psychopharmacology, and I've noticed an awful lot of calls from patients seeking consultations, but they're not really psychopharmacology second consultations. They're more catastrophic life circumstances going on, and a lot of things are just going wrong all at once, and it's far more than a psychopharmacology input can really address. It's a lot of people that need just simply a higher level of care, intensive outpatient programs, partial hospital programs, patients who might need ECT or ketamine, patients who take long-acting injectable antipsychotics. Those are hard to administer over Zoom, right? Patients who need vital sign assessments, blood pressure checks, weight monitoring, lab monitoring, AIMS evaluations for movement disorders. So there's a host of things that, I think before anybody gets too cozy and complacent with telepsychiatry, particularly if the clientele that we see has more serious forms of mental illness, such as bipolar disorder, my interest, or schizophrenia, or even forms of severe depression, telepsychiatry is okay. I think it's a stopgap measure, but I'm very worried about patients with higher needs for whom telepsychiatry just may not be enough. And as time marches on, I think it's going to be an increasing problem because you can only temporize for so long.
Yeah. What are some advice that you can give to a patient suffering from bipolar disorder? Like if you can list maybe like the top 3 advice that you would give to prevent them from relapsing.
So stay in touch with your regular routine. Your regular routine means your daily social rhythms. It means not saying, now is maybe a good time to take a medication holiday and see how I do. Now may not be the time to do an experiment of I want to see how I do coming off of a certain medicine or making drastic changes. You want to kind of keep things in equilibrium as best as possible. So there may be an instinct to say, I've had a few patients say, I'll see you when your office reopens. And I don't know when my physical office is going to reopen. And I'll say to patients, I'm following the CDC advice and no other advice. And that means when the epidemic is no longer an epidemic, and it's safe for them as well as for me and their family and my family to do face-to-face in-person appointments again. And I don't know when that's going to be. Nobody does. So until that point comes, I have optimism we're going to have a vaccine. I have optimism that we're going to have better mitigation strategies than we have right now. But until that time comes, let's not let anything fall through the cracks. So that means keep your appointments, stay on medications, know the warning signs of mood episodes, know the risks of comorbidities. Most people with bipolar disorder have a second or third or other psychiatric ailments, such as an anxiety disorder or a substance use disorder. So know what to look for, be vigilant. And one other point that doesn't always get talked about. So we're all at home right now. I'm in my home, you're in your home, everyone's in their home with their families huddled together. And in some ways, I think in the early phases of this epidemic, there was a sense of togetherness and bonding, and here we are, and we're getting through this as a family unit, and all of that I think can be very true. But at the same time, it's a concentrated dose of family. There's loss of privacy. There can be all kinds of interpersonal factors that may come up. And one thing we know in the world of bipolar disorder is that interpersonal factors can play some role on mood changes. And within families, within nuclear families, things like expressed emotion and communication styles can play a role as well. So high emotional over-involvement and criticism within families can get amplified in kind of the crucible that is, we're all in this home together. So I think it's very hard to be able to say to yourself or your family, I need a break. I need a place to go right now. The patient I was just talking with this morning who was talking about this very concentrated dose of his family that he's getting. He needs some breathing room. So I think it's okay to let patients know it's fine to say, I need a timeout, I need some alone time for myself. It's very hard with doing homeschooling and keeping your day job or managing a family and doing 10 things at once. So self-care becomes really critical, and one of the messages I always try to emphasize with my own patients, as well as myself and my family, is you have to take care of yourself before you can take care of anybody else.
Yeah, I think you very aptly described what millions of households in America are going through right now with their families.
It's hard, but and everybody's going through this together, and with the social distance, physical isolation, we need reminders of that it's probably very similar under my roof as it is under yours and someone else's, and there's some, I think, strength we could derive from just that knowledge alone.
As far as the resources out there, are there any that you find particularly helpful or impactful as you navigate your practice through this pandemic? So some things that you've leaned on?
A few things. So I didn't fully answer the question of the role of psychiatrists. I mean, I think part of it is providing crisis intervention and supportive listening and assessment for major forms of psychopathology and substance, and making sure people are taking care of themselves. Part of it also is, on very basic levels, helping patients navigate through the great turmoil and distress that they might feel. So that may include giving advice around things like relaxation techniques, mindfulness-based meditation behaviors, journaling, exercise, and things like that. So there are some resources that I have drawn on and find useful. Apps, for example, that are focused on mindfulness and meditation and relaxation techniques that I've steered patients toward. Techniques like journaling can be helpful. So making use of resources around relaxation techniques, mindfulness can be very helpful. The American Psychiatric Association happens to have some wonderful links on its website for strategies for professionals as far as counseling is concerned. If you're a healthcare professional and you find yourself in the position of doing crisis work, knowing how to just actively listen to someone, how to be able to sort of help someone just get through a very difficult time. A lot of it is just active listening and taking care of their basic needs. So the APA website, I think, has some useful information there. PsychU has, I think, fortunately had a number of interviews with experts and clinicians who are sharing their perspective and experience, and I personally find that helpful, just to know that other colleagues can talk about things that resonate with my own experience. There's also, I think, just valuable basic information about taking care of mental health conditions on the PsychU website, so I always encourage colleagues to make sure that they're going to reliable sources. I think one other risk in this pandemic era is there's a temptation for news hunger and information hunger, and some of it is more reliable than, especially when it comes to healthcare information. So we want to make sure we have trusted and reliable sources, and because headline-grabbing news stories may not necessarily reflect the most rigorous information about, say, the forecasting the upcoming mental health epidemic or interactions of psychiatric drugs with drugs for COVID. I think we want to just remind our patients and ourselves that if you're going to look online for information, just make sure you've got a trusted source and you're not getting information that's not really been well vetted scientifically. And I think PsychU is very well vetted.
Thank you, Dr. Goldberg, for that insightful perspective. Any final thoughts to the PsychU community?
You're not alone. And I think outreach becomes important. I don't know about you. Many of us are sick of Zoom. We're sick of the tele format right now, just because I think it's a reminder of what we don't have. But at the same time, it's contact. It's a way of keeping connected with people. This is a time that really calls for creative problem solving. And building resilience means problem solving skills. So I think anything and everything people can do to focus on honing their problem solving skills is in the service of trying to build the resilience and maintain optimism so that we can all get through this catastrophe and get back to something more close to normal life, which I have every hope and expectation will happen. Maybe not as soon as we wish, but every expectation it will.
Thank you, Dr. Goldberg. With that, we are out of time. Before I go, I want to thank you to our audience for joining us for our segment on Bipolar Section Advisor Perspective on the COVID-19 pandemic, which was brought to you by PsychU and sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Lundbeck LLC. Thank you and have a great day.